Minister Modi has called it the biggest universal health plan unveiled by any government across the world in what has been touted as a political masterstroke ahead of 2019 general elections. Finance Minister Arun Jaitley announced it in the budget 2018 that the government will provide medical cover of up to 5 lakh rupees to 10 crore families free of cost. But economists and healthcare experts are not very amused and either impressed. While Jaitley has set aside about 2,000 crore rupees in the budget, the market believes that the actual cost may be in excess of that. Not just that, the back of the envelope calculation showed that the state government will have to shell out over 40% of that in the next fiscal. Will they be on board is really the big question. Considering the poor financials of the state, many doubt if they will be ready to put their part of the bill. On the India development debate this evening, we raised some very key questions. Is the Universal Health Plan just a good political slogan, or will it perhaps lead to sound economics? From where will the money come from? More importantly, in the absence of standard rates for common treatment, how will the scheme be implemented at the national level? Very much for joining us, Shamika Ravi. Is India really serious about healthcare? When we talk about schemes like this, and then when we look at healthcare allocations in the budget, this year we've allocated under 3% over the last year's revised estimates, just a 2.7% growth on allocations over the RE of last year. What does this tell us about a priority to treat healthcare as an area of importance? I mean, all of this political compulsion set aside, allocations don't justify this priority area.
Well, Supriya, I think the announcements do matter because we have been exploring universal health coverage for quite some time in this country. In fact, the deliberation started as early as 2012, but I think because of lack of political will, this was not rolled out, at an all India level. That is number one. Number two, the question on OPD, it is correct that if you look at the National Sample Survey, a majority, in fact, almost 70% of the total out-of-pocket that households pay is for OPD. And I think this is where I think the media's coverage of this year's budget announcement on healthcare, which in my view has been a fundamental shift in prioritization of healthcare, has been unduly focused only on the health insurance scheme, which is the National Health Protection Scheme. The second part of Ayushman Bharat was the wellness centers. And the wellness centers are OPD essentially and meant to be that gatekeeping, the first point of contact of citizens to the public health infrastructure. So, strengthening of the wellness center is largely to take care of that first order requirement in terms of the OPD. Now, going to your specific question on the allocations do not justify, or signal a low priority. Actually, I'd like to explain that, allocating funds in the current situation, particularly in healthcare, is perhaps the easiest thing to do in terms of bringing in reforms. You can allocate the funds, but the state capacity does not exist to absorb this kind of allocations. That's a very important binding constraint that we have to be cognizant of, because there are several ministries where we do have underutilized, unutilized funds sitting. So that's an important point to keep in mind. Thirdly, as far as the health insurance schemes are concerned, the publicly financed one, this particular scheme is really meant to defragment the National Health Insurance Protection Scheme. We have had RSBY in the past, since 2008. Of course, the coverage was more meager, it was limited. In terms of just the outreach itself, it was pretty low. But different states have had. Arogyasri has been functioning in Andhra Pradesh now for almost 15 years. 12 years. We've had Vajpayee scheme functioning in Karnataka for almost 15 years. Tamil Nadu has its own set of schemes. So now states have been experimenting, but this is an attempt to basically defragment that, bring some degree of uniformity, and yet allow the states to, add on and provide the additional benefits that they can afford to. But this announcement is a fundamental shift towards universal health coverage, and in my view, actually a significant one.
Shamika Ravi, if I may talk to you, and I think one of the points that was discussed earlier is how this is going to help states come on board. I mean, 40% of the cost reportedly is going to be borne by the states. Some states already have some of these very well-oiled schemes running already with their own branding. It has been very successful. Why do you believe states will now play ball? Because a lot of the states that are progressive, that would have rolled out a scheme like this, have already done so. Why will they stand now to be subsumed by a scheme like this? Why will they play ball?
Well, one thing to note, and I think it's missing from the discussion on the premium as well, is that, for this market segment, the claims to coverage is actually quite low. It is significantly lower than the mainstream, health insurance claims to coverage for the mainstream market, which of course means that most of the time people do not know that they are covered, and therefore it's actually more profitable. Now, in the long term, what it means is that we have to educate people, we have to train them in terms of understanding exactly what that coverage means, and encourage them to file claims when they do have genuine cases. The other is that, the experience in Andhra, etc., have shown us over the last 10, 12 years that what are the IT systems, what is the HMIS system to detect fraud. So there is a considerable learning that has happened over the last 10 years, and which will be, which is being used to sort of design what the exact nature of NHPS will be. Now, the reason I think states will play ball is because I think a fragmented health insurance market or a health care market is a dangerous one, particularly in a country where actually, a significant amount of seasonal migration happens to seek health care. People are constantly moving from rural to urban and from tier 3 to 2 towards metros to seek health care. I think, that portability of instruments is extremely critical in a health, market like India. The other thing to note is that, while we constantly keep talking about OPD, and OPD being the biggest sort of the, component to out-of-pocket health burden for households, it's important to know that, despite rolling out health insurance in small amounts, the experimentation, in the last 10 years, while OPD expenses per household has increased by, let's say, 10, 12%, IPD expenses per household has actually gone up 66%, which means that, households are considerably burdened by hospitalization fees, etc. This is pertaining to Dr. Shetty's point about catastrophic health expenditure. So whether you calculate it at 10% of your household expenditure or 45%, 66% increase within 10 years, and this is real expenditure, is a significant burden on households. And to that effect, health financing being provided, support from the state is, again, it's a very welcome step.
I have a quick question before I move on to the private sector participation. And Shamika Ravi, this is really coming your way. I think we alluded to this a little while back, but just want to ask you in more detail. A lot of experts out there believe that this scheme redefines the state's role from being a service provider to being a financier of sorts. Is that going to be an easy transformation?
No, well, first of all, I don't think that is a correct perception. The state is not, in fact, the state is not abdicating its basic responsibility to providing primary care and preventive, and in fact, a fair bit of secondary and tertiary as well, but the focus being on primary and therefore the wellness center. But the move towards financing is also a critical one, because we know that 7% of Indians fall below poverty line because of health expenditures. Now, that number actually has not changed. It still remains 7% after 10 years of sustained growth. So what that is telling you is that, at levels of poverty that we have, people are falling further back because of health, and that is where affordability and equity concerns and inclusive growth from a larger perspective has to kick in, and that is the role of the government. So by that logic, I think the government is really trying to balance equity and affordability in terms of hospitalization, with basic, almost right to primary care for every citizen. So yeah, I do not think this transformation, and I hope this doesn't catch people's fancy. State is not a financier. It's only for the poor.
Yeah, there is no doubt that people are left impoverished once a disease strikes a family, once an illness strikes a family. Is there a case whatsoever of regulating medical costs? I mean, one of the things that we said initially in our arguments was that there is absolute absence of standard rate of common treatment. For the same illness, the rate of treatment differs from hospitals to hospitals. Private hospitals charge you to the teeth. The question is there a case, is there merit in the argument that is now beginning to make? Is there a case to clamp down on these costs, to regulate costs?
Well, so I don't want to use the word clamp down, but regulation is absolutely fundamental to growth of any private sector. particularly when it comes to healthcare, when information asymmetries are so much. Doctors are treated as God. There's complete trust that patients have when you put yourself in the hands of the doctor. So that kind of an information asymmetry means that there is a fundamental role for a regulator to oversee these kind of transactions. Now, what is going to be the central role of a regulator here? It's not as much price control, Supriya, as quality control. In fact, in India, we haven't started talking about quality of care. The world is moving towards quality of care, while in India, the National Accreditation Board of Hospitals, NABH, does almost entire accreditation based on input and output. So how many beds do you have, how many X-ray machines, number of patients per doctors, etc. So we need to now gradually move towards now quality of care. What exactly does that require? Well, that requires, one, for us to have a basic framework of what is that minimum amount of data that the government requires or a regulator requires from the private hospitals at an aggregate level. You don't necessarily need to share at patient level, but at least on an aggregate level, a hospital should be sharing certain information with the regulator. And frankly, the private hospitals are not averse to that. I think, which is basically telling you that the need is now absolutely urgent that we create this regulatory body which does this kind of an oversight. Right. Now, one fundamental point going to that artificial scarcity, there is a 3:1 ratio of number of seats of MBBS to PG. So artificial scarcity, I could not have said it better than what Dr. Devi Shetty has done, and that is why it is important that that NMC bill actually passes in the parliament despite the pressures that you are seeing all around you to delay it.